Assalamu alaikum. It's a new series where I will discuss about gynecology and ops um, topics, most likely serially from A to Z. Start with this alpha reductase or 5 alpha reductase deficiency. Okay, before jumping into the box, I would like to discuss about something important about 5 alpha reductase deficiency. It's a rare autosomal recessive. These are the key points. It's a rare autosomal recessive disorder of sex development, impairing the conversion of testosterone to dihydrotestosterone. It impairs the conversion of testosterone to dihydrotestosterone. Patients with 5-alpha reductase deficiency. Patients with 5-alpha reductase deficiency, if we look at deeply in 5-alpha reductase deficiency, what happens? Like dehydroepiandrosterone is converted into androstenedione. Dehydroepiandrosterone is converted into androstenedione. These androstenedione uh, is converted into testosterone. This androstenedione is converted into testosterone, and then this testosterone is further converted into dihydrotestosterone with the help of an enzyme called 5-alpha reductase. So dehydroepiandrosterone is converted into androstenedione, and androstenedione in the peripheral tissue. Um, in the peripheral tissue, uh, androstenedione is further converted into testosterone, and testosterone is again converted into dehydro dihydrotestosterone with the help of 5-alpha reductase enzyme. If this enzyme is low, dihydrotestosterone is low, so impair conversion of testosterone to dihydrotestosterone. So patients with 5-alpha reductase deficiency have 46 XY genotype but have a normal phenotype. So they have 46 XY genotype but normal normal female phenotype. So they have normal female phenotype like external female genitalia at birth and experience realization in the form of clitoromegaly, increased muscle mass in the puberty. If we look at the pathogenesis of the 5-alpha reductase, there are two types of 5-alpha reductase that convert testosterone into dihydrotestosterone. Type 1 is present in post. There are two types, type 1 and 2. Type 1 is present in post-pubescent skin, and type 2 is predominantly found in the genitals. So type 1 in post-pubescent skin and type 2 is predominantly found in the genital. 5-alpha reductase deficiency is caused exclusively by defective type 2 enzyme. So 5-alpha reductase is exclusively caused by defective type 2 enzyme. The lack of dihydrotestosterone leads to abnormal sexual development beginning in the utero. On development of internal genitalia in utero, the gonads of the genotypic male in the utero, gonads of the genotypic male 46XY are differentiated into testes under the control of the sex determining region of the Y chromosome, that is called SRY gene, and testicular Leydig cell. We know that if we think about SRY gene expression, if we want to think about the SRY gene expression, like if we look at here, SRY gene on Y chromosome, SRY gene on Y chromosome actually stimulates TDF, testis determining factor. This testis determining factor, development of testis from where undifferentiated gonad, undifferentiated gonad. Undifferentiated gonad stimulates Sertoli cell, stimulates Leydig cell. Sertoli cell stimulate anti-Mullerian hormone, and this causes involution of the paramesonephric duct. This causes involution of the paramesonephric duct, and Leydig cell stimulates testosterone. Leydig cell stimulates testosterone. Testosterone is further divided into dihydrotestosterone, and testosterone actually stimulates the Wolffian duct to form male internal genitalia, and dihydrotestosterone, genital tubercle of the urogenital sinus, genital tubercle of the urogenital sinus actually stimulates male external genitalia. So, Leydig cells stimulate testosterone, and with the help of testosterone, Wolffian duct actually causes to form the male internal genitalia, and testosterone is further converted into dihydrotestosterone. So, genital tubercle and urogenital sinus is here. So male external genital penis posted PPS, penis posted scutum, is formed with the stimulation of dihydrotestosterone. In this condition, in 5 alpha reductase deficiency, testosterone cannot convert it into dihydrotestosterone. So male internal genitalia, sorry, male external genitalia is absent, but male internal genitalia is present, because we know that testosterone is present. So with the stimulation of the testosterone, Wolffian duct actually make the male internal genitalia, but testosterone unable to convert the dihydrotestosterone. So as no dihydrotestosterone, genital tubercle or urogenital sinus unable to form male external genitalia, penis and prostate. Okay, okay now. So testicular Leydig cell actually produce testosterone, which binds to the androgen receptor of the Wolffian duct, causing proliferation uh, and development into the male genital duct. Epididymis is the first difference. This process occurs in patients with 5-alpha reductase. This process occurs normally in patients with 5-alpha reductase deficiency, because the enzyme is not required for this process. So for forming male internal genitalia, to form 5-alpha reductase enzyme is not present. Anti-Mullerian hormone AMH produced by the testicular Sertoli cell causes regression of the Mullerian structure. Therefore, patients with 5-alpha reductase deficiency lack of internal female genitalia. As there is 5-alpha reductase enzyme is deficient, there is lack of female internal genitalia like fallopian tube, uterus, and proximal vagina. So anti-Mullerian hormone is produced by the testicular Sertoli cell, causes regression of the Mullerian structure, and therefore patients with 5-alpha reductase deficiency lack of internal female genitalia. And if we think about seeing the development of external genitalia, Some of the testosterone produced by the testes is converted into dihydrotestosterone by the enzyme 5-alpha reductase. Dihydrotestosterone binds to the androgen receptor of the genital tubercle to promote differentiate into external male genitalia penis. Because dihydrotestosterone is absent, again I have saying that testosterone is unable to convert the dihydrotestosterone, as these dihydrotestosterone is absent. So mm, as the dihydrotestosterone is absent in males with 5-alpha reductase, the genital tubercle differentiate into female external genitalia. Lower two-thirds of the vagina, blind pouch, vulva. In addition, because dihydrotestosterone mediates testicular descent and the testes are undescended, cryptorchid. Testosterone levels are within the normal male range within the normal male range due to intact negative feedback within the hypothalamic pituitary gonadal axis. However, at puberty, physiologic increase in testosterone leads to virilization and phenotypically female patient through the action of the 5-alpha reductase type 1. This can manifest as nodule cystic acne, clitoromegaly, clitoris producing from the clitoral hood. Additional features visualization include voice deepening, increased muscle mass. Because testosterone levels are within the normal male range for puberty, patients develop additional normal secondary sexual characteristic axillary and pubic hair. However, patients have no breast development because testosterone binds to the breast androgen receptor and inhibits breast tissue proliferation. Clinical presentations vary based on the timing of the clinical presentation. At birth, unvirilization leads to predominantly female external genitalia. However, features may range from mild clitoromegaly to isolated microphallus, with or without bilateral labial mass cryptorchid testis. Commonly, patients who are assigned female gender are at birth present in adolescence with primary amenorrhea in the absence of menarche and with virilization clitoromegaly. The following feature: no breast development due to testosterone inhibited breast proliferation, blind ending vaginal pouch, absent Mullerian structure, uterus, fallopian tube, normal pubic hair and axillary development, virilization characterized by clitoromegaly, increased muscle mass, and male pattern hair development and nodule cystic acne. Diagnosis the diagnosis may occur during the newborn period if ambiguous genital clitoromegaly or microphallus are present. However, classically, the diagnosis is delayed until adolescence is those assigned female gender at birth who then present either primary amenorrhea or rapid visualization. The diagnosis is suspected based on clinical findings and is confirmed through lab and imaging. Findings include lab evaluation, elevated testosterone to dihydrotestosterone ratio, confirmatory genetic testing with identification of the mutated gene that encodes 5-alpha reductase, imaging, ultrasonography to evaluate internal genitalia reveal absent Mullerian structure, uterus, fallopian tube, and identify undescended testes, MRI to visualize detailed anatomy of the pelvic structure in the planning surgery. If we look at the differential diagnosis, if we look at the differential diagnosis, so androgen insensitivity syndrome, Mullerian agenesis, female gonadal dysgenesis, and classic congenital adrenal hyperplasia may be thought. Management is like based on the degree of the genital ambiguity and uh, gender identity. The mainstay. Finally, if we read this box, this 5-alpha reductase deficiency. So genotype is 46XY genotype. Impaired conversion of testosterone to dihydrotestosterone. So with the stimulation of the testosterone, male internal genitalia is intact. But as there is no dihydrotestosterone, male external genitalia is not grow, and there is female external genitalia, and there is impaired virilization during embryogenesis. Normal male testosterone and estrogen level. There is male internal genitalia, female external genitalia, phenotypically female at birth, and virilization at puberty due to increased testosterone. Virilization at puberty due to increased testosterone. There is clitoromegaly, increased muscle mass, male pattern hair development, and nodule cystic acne. Clitoromegaly, increased muscle mass, male pattern hair development, and nodule cystic acne. There is elevated testosterone or dihydrotestosterone ratio. So that is all about 5-alpha reductase deficiency. Hope you enjoyed.